Good afternoon, everybody. Welcome to today's Coventry HDRC lunchtime webinar. Today, Dr. Adeniyi from the Coventry University into us and using data to understand health outcomes, and be taking us through different kind of secondary data and case studies. So I'll be handing over to him shortly. But for your information, we're recording this session and we'll share that after the session, and also we'll be able to share the slides with you. So thank you very much, Dr. Adeniyi. Over to you.
Okay. Thank you. I will share my screen now. I think we should be able to see my screen. Just can you confirm that you can see the screen? Okay. Thank you so much, Michael, for your kind introduction. And as we can see, I've modified the topic just slightly. And today is my pleasure and, of course, a privilege to meet colleagues and share with you my thoughts on how we can leverage secondary data to enhance health outcomes in our society. My background is in medical statistics and health data science. So I will be talking to Ross, going through these outlines, which we will see in the due course of my presentation. So to start with, what is a secondary data? Secondary means, not primary, so to say. It means data that has already been collected. So we can use secondary data for analysis to be able to explore health outcomes, to be able to plan for health, to know whether intervention is working, to plan intervention as well, and for different things. So I'm going to quickly, before we see how we use it how we can use it to enhance health outcomes, we are going to look at the different sources of data, the types of secondary data, and categorization of secondary data, and how it has been applied. Then I will now come back and talk to us about what we need to do or what we need to bear in mind when using secondary data. I know that a lot of us here would have been using secondary data one way or the other, but the purpose of this webinar is just to remind us, if I can use that language, how we can still use this thing for better health outcomes in our society. So there are two major sources of data. We have the regular sources, and we have what we call the ad hoc sources. So what are the regular? These are the data that are collected continuously. They are usually collected via sensors, vital registration system in hospitals, in ports of entries, in airports, in seaports, and so disease notification center, electronic health record. These are just some examples of the regular sources of data. And also, like I said, we have the ad hoc sources. These are the ones that are not usually collected day to day, but they are typically planned for a particular purpose. So they include the surveys and experiments, the planned studies, well-designed with measurable objectives. We have a special sample survey. You can say government wants to do a surveillance survey around when there was COVID-19 outbreak. It can be ad hoc survey on environmental health, monitoring potentially harmful chemical, biological agents, and so on and so forth. So these are the broad sources of our data. But when we look at the type of secondary data, it includes the use of administrative data like insurance company, even hospital management, the number of stock they are taking in, and so on. Drug stocks and even consumables in the hospitals. We have the clinical data, which contains the health information of individuals. Maybe when they came, they are diagnosed, when they were given prescriptions, and so on and so forth. Another type of secondary data is the population health survey, like the popular NAHES, the NASTA, the DHS, whereby you conduct this type of studies to be able to understand the dynamics in the general population. And another type of secondary data are those repositories that are deposited in our various research databases, and it contains different types of data. So when we now talk about classification of secondary data, this is the way we can now put it in much closer perspectives. We have different types, but I've just named six here, the six commonest. We have the panel, which is the same thing as cohort studies. We have retrospective household survey, cross-sectional studies, censuses, surveillance data, and of course the electronic health records. So I'm going to speak to each of these one in quick successions. The first one we are going to quickly look at is the panel data in the UK. Like I said earlier, panel data, they are the same thing as cohorts, but they have slight difference, but generally they can be referred to as the same. And panel data in most cases is based on aggregates. For example, we can talk about postcodes, we can talk about wards, we can talk about local councils, we can talk about nations in the UK, and we have their data over the years. That is a panel data. But in most cases, longitudinal data are typically about individuals, sublevels. So what are the types of panel data that we have in the UK that we can actually lay our hands on? The first one I'm presenting here is the Millennium Cohort Study. It's a very rich study that started in year 2000, 2001, that started with people from the day they were born, and they are being followed up. Currently now, people in this study are about 24 years old, and it's data about everything about them, starting from walking, talking, entering primary school, entering university, graduating, learning trades, even crime, all sorts of characteristics as they evolve, when they begin to get married, when they have any ailments or any long-term conditions, everything is being documented so that the trajectory of whatever happens to them can be known, understood, and be used to plan for health of people that will come behind them. Even it can still be applied for people even ahead that were born before them. So it remains a very rich source of data. As you could see, I will have provided barcodes to each of them, and of course the link to them, so that when we get the slides, we'll be able to go into them in details. Another example, a panel survey, is the British Household Survey, which started in 1991. It has now been archived, but the data is still available. It's equally very, very rich. It followed the same representative sample of individuals over a period of years between 1991 and now. It's very rich. It can be used for different types of research. Another example is the Understanding Society, the UK HLS data. That one too is the one that took over from the British Household Survey in 2008, and it remains one of the largest longitudinal household studies in the world. It has annual data on individuals and their households across the UK. It provides insights into socio-economic as well as health changes over time, and is very rich. You can see what the information it provides. This is what we can one of the data that we can actually leverage on to understand the health outcomes and other associated characteristics of our community members. Another survey which has been used over the years is the Labour Force Survey in the UK. It's a quarterly household survey of employment circumstances in the UK, a cross-sectional survey with panel components, because individuals are surveyed consecutively for at least 5 years. And when you get to their dashboard, this is what you see, promoted by the Office of the Office of the National Statistics, telling us about the employment rate among the active, the 60 to 64, or the inflation, the GDP in the country, and of course our current population. Another one is the English longitudinal study of aging. It's studying people as they are growing old. What are they? It's usually pertaining to their health, having long-term conditions, and so on and so forth. This is it follows older adults, age 50 and over in England, and focusing on their economic, social, and health circumstances. And the participants is well over 19,000, and a massive 1,300 publications has been made from this study. So it means that it's a very rich data that we can easily leverage on for our studies and activities. So the second one I want to talk about is the electronic health records, which are one classical example of routine data. I've separated them from the panel because it is one of the well used, and I will give us instances where I've been involved in big collaborative studies where we have leveraged on EHRS. So what are EHRS? They are longitudinal accumulation of health information collected during healthcare routine. They are basically hospitals and GP related data about individuals that are seeking help. Very useful, yet economical sources of data to understand health outcomes. It collects and stores a patient's health information over time, and the data is ongoingly recorded over time. So it's always there, it's accumulated. But it can be very messy because it is complex and also very large. Nonetheless, despite their usefulness, like I said, they are very complex. Of course, they may require complex analytical skills, and anybody that wants to use them should be ready. Should be ready for this. Where have I used this in the time past? I will come to that, but they have several advantages. I've just listed I mean usefulness. They have just listed a few here. They are very useful in improving communication between professionals, healthcare professionals. And of course, it gives us access to medical information to be able to study it more and make suggestions, recommendations that can influence the practice. It creates a repository of clinical data for research and audit. It helps in understanding epidemiology of common and rare conditions. It helps in improving health and the strategies. And of course, it contributes to pharmacogenetic studies, how to develop drugs that can be suitable to measure this. So, like I said, it can be very complex and messy. So we need special skills to be able to use EHR as adequate. Imagine you go to, you are collecting data and you are seeing somebody alone, maybe for a particular patient. He has visited the hospital more than 30 times within a year with different conditions, complaining for different things, and being assisted in different ways. It can be very complex, but they can still be done. So there's a need to understand the design of that type of electronic health records and what we want to use it for. How do we want to design our study? It will also require in-depth exploration. You need to explore it in details, creating data sets using various study designs. That is, creating a sub data set from the major one to be able to align with our research interests. And of course, there will be a need to create a code list creation and use them appropriately. And of course, there's a need to understand what constitutes exposures, what constitutes outcomes and covariates, and how they are measured. We need to really, there's a need to understand this. And of course, there's need to be able to understand causal inference. Can A cause B or B cause A? We need to understand it in EHRS before we can use it effectively. And another thing is that which method will you use to assess this causal inference or the linkages or relationships we are talking about? These keys are very necessary when handling electronic health records. Like I said, I've been opportune to belong to different studies across the UK whereby we have used it. The first example I will show is the SAIL data bank. I think is the data records of people in ways among here we look at subclinical hypothyroidism in Wales from 2000 to 2021. And this study contains about 304,000 people. This is the huge advantages of secondary data. Imagine if I want to do this, how can I and my team get a population, a response of 304 individuals? I believe that would be a nightmare. It's not going to be easy. So with availability of electronic health record, we can easily do this. Another one is the National Health Records in Scotland. Here, I led this particular study whereby we look at the long-term conditions among adults in in the UK. We were able to cluster them. How does this disease occur among people within this community? It was T and 5 areas very close to Dundee in Scotland. We carry out this study, and again, we started with 318 individuals, but we were only able to establish multimorbidity among 67,000. Again, this is a huge advantage of using EHR. It will be a nightmare to get this on our own without leveraging on secondary data. Another example is this one. I belong to this group, still in Scotland, at the outbreak of COVID-19 in 2020. We set up this surveillance, the yearly pandemic evaluation and enhanced surveillance of COVID-19. We call it IF2, that's the short name. And it looks at eventualities of COVID-19, people taking the jabs. You took one, which type of jab did you take, how many have you taken, and so on and so forth. And this particular collaboration has led to more than 50 publications in high-profile journals. Again, that is the power of secondary data. Like I showed here, about 2.57 million individuals were involved in this study. There's no way we could have done this easily without setting up a mechanism that can help capture this data, and we can use it for the betterment of the society. Another one is the biobank, which is accumulation of different data from different sources. Again, very useful. Here we look at profiling of people that have experience that we are profiling alcohol consumption in the UK, and we leverage on the UK biobank data to do this, and it was published as well. About 35,000 individuals were involved in that study. Another thing, this is the England version of Wales sale. We call it the CPHD data. It's a very large database in England that one can leverage on as a secondary data. Here as well, we look at polypharmacy. Polypharmacy is having multiple medication during pregnancy and the factors associated with them. Here we explore 577 different types of medications among 1.5 million pregnancies within the UK. And we follow them. If you are saying, okay, well, which medication did you take during pregnancy and so on? Because we can imagine how would we have gotten 1.5 million pregnancies if not with the help of secondary data. So secondary data, they are very, very useful, and they can make research. They can make not just research, but understanding the health dynamics and making recommendations, and of course influencing policies. They make it very easy for us to do. Apologies, you can see that most of the work I've been showing you are the ones I've been involved in. So apologies, maybe I'm biased about that, but definitely different researchers have done tons of research using secondary data all over the country. And outside the UK, I remember this one. I wrote this paper with Mas Petsot. He hosted me in the University of Gothenburg in 2019, just for 2 weeks. I'm showing this particular one that if you have your research objectives, what you want to study, and the data is available, you can leverage on it. I visited him for 2 weeks, and we discussed what are we going to achieve within 2 weeks. And he told me about this data. It's a Swedish birth cohort, people that were born as from 1985, they were monitored in 2015, and we're looking at the risk of them developing diabetes by the type of their conception, whether it was artificially, whether their pregnancies were artificial or they were natural, and so on and so forth. So this is the power. This is one of the powers of secondary data that we can leverage on. Within 2 weeks, we started this study. Although we didn't complete it within 2 weeks, I was able to complete when I returned into the UK, and it was published. I think I have about 3 or 4 publications from this particular visit. Those are the power. And again, similar data like that, they exist. I was able to look at a Coventry Council website, and I could see that a lot of data that we can even use locally in our community that we can trace to each location. I mean, in terms of postcode in the local council, these are some of the things we can leverage on. Yes, here I've called the zoom in on EHR, but I will not be talking so much I will not be talking so much about this because of time, but I'm leaving this particular slide for those of us that are interested so that we can do it. Just talking about the key challenges and how to improve when using EHR. It's very rich and very coincident. That's why I've left it there. Please, we may wish to take advantage of it. So quickly, let us talk about cross-sectional data, a very important and very useful sources of data. What is a cross-sectional data? This is a type of data we call a snapshot. A snapshot means that you take your camera and you take the picture and off you go. That is what cross-sectional, you don't look back. You just ask your respondents the questions and they give you their responses. Is you are not doing follow-up, you are not assessing anything. It's only what you get at that point that you capture, and it provides a snapshot of the population, giving us insights into characteristics such as their income, their education, their health, their health exposures, and health outcomes as well, employment status, but we don't track changes over time. It has its own limitation, but it is also very rich. In the United Kingdom, we have the Health Survey for England, for example. It's an annual survey that monitors the health of the general population in England, providing data on health status and behaviors and conditions. About 8,000 adults have been enrolled, and this very rich. Different publication has come out of it, and which have been very useful too. Another example is the British Social Attitude Survey. Is conducted annually too. This survey measures public attitudes. It's conducted annually. What makes it processional is that you don't go back to last year's participants. You can choose another set of participants, and the methodology is valid. It's equally good, and of course, people have used it to understand the dynamics in our social, political, and moral issues in the United Kingdom. This is a very popular survey, the NATSA survey, which is a survey of sexual attitudes and lifestyles. This has been explored. They can see the snapshot about the methodology used. It's conducted every 10 years since 1990. The latest was in December 2023, randomly selecting people face-to-face interview. It has so many series, and it makes it quite easy to see changes in behavior, in attitudes of people as far as sexual life is concerned, and so on and so forth. So these are things we can leverage on. And the good thing is that if our communities have been chosen as participants in this survey, then we can localize our analysis and use it to make policy, even in the like, for example, in the Midlands or in Coventry Council, if they were part of the study. Yeah, because there are so many of them. So many types of cross-sectional data. Even within the UK, we have the Family Resources Survey, we have a crime survey for England and Wales, we have living costs food survey, and we have the National Travel Survey. All of them are very, very useful, and they've been used in the past to understand the dynamics in our society. But when you look at this data carefully, you see that everything is connected one way or the other to health. Even when you look about housing data, you can see bring health, because I don't know, health is very central to everything. So we can actually leverage on this. I've been talking about UK, so let me just spend the next few slides to talk about outside the UK, because as a researchers, we are not just come into our locality. We can look outside our borders and see what is happening, or when you want to compare what is happening in the UK versus other countries in the Europe, or versus other countries in the high income countries, or even the low and middle income countries. So there are several examples. I've just listed 8 here. We have the demographic household survey, which is a type of survey conducted every 5 years in consenting low and middle income country. I think it is sponsored by ICF Macro in the United States, in collaboration with the Department of Population in every country that is participating. We have the multi-cluster indicator survey. We call it MIX. It's owned by UNICEF. UNICEF does this to understand and help children. There's National Health and the Nutrition Examination Survey, the NAHIS. We have the Bureau of Statistics, which is equivalent of Office of National Statistics in the UK. We have community health surveys, Eurobarometer surveys, national household sample surveys, and the national family health survey. These are different countries adopts different one. We may not have each and every one of these in a particular country, but of course they will have at least one study as shown. So I will quickly show you what I've done outside the UK, which have got some applications of cross-sectional data. For example, in this particular study, with some of my colleagues, we look at the what contributes to disparities, that is wealth inequality in under 5 deaths among in low and middle income countries. As you can see, low and middle income country does not because United Kingdom is a high income country, it will not be one. But like I said, we can actually explore secondary data to studies where even the places we've never been. For example, when you look at this is the world map, and the study consists of the countries in each of these maps. Sorry, in each of the map, the upper one and the lower one, and we're able to look at under 5 deaths globally. Well, what are the burdens and so on? This is per 1,000 life deaths. What it looks like. And of course, I've never been to I've never been to most of this country. Okay, for example, in this particular one, we leverage on the DHS data, that's the demographic health survey, to look at the incidence of diarrhea among under 5 children globally. And in this particular study, nearly 800,000 under 5 children were involved. About 64,000 communities were visited across 57 countries. We agree with me that this is not just possible. If I'm to do it there by my own, maybe it will take the next 10 years to plan and implement. But with the power, with the availability of secondary data, we were able to leverage on this and make sense out of it. This is another example of genital mutilation in Africa, whereby we are looking at number one, for women that have their genitals mutilated, and they still doing it to their own children. Because it's not a big issue in the UK, but it's a big issue in the low and middle income countries. And we're able to carry out this study. We're able to pay because the women were asked, were you circumcised? If yes or no. Was your last daughter circumcised, yes or no? And we are able to link about 93,000 of them, which we call women daughter pair, across nearly 8,400 communities across the 14 countries in Africa, for example. Is the power. This is the details of the result of that finding. For example, the upper map of Africa is showing the prevalence of genital mutilation among mothers. And this the lower map is showing the prevalence among the children of these people. And we can see that it's actually reducing over the year. So studies like this will help in policy formulation and how things can be made better for people that are affected or concerned. This particular study, this is a NAIN study, the National Health and Nutritional Examination Survey in the Republic of South Africa. Here, I wasn't even in South Africa. I was able to lay my hands on their data with some of my colleagues, and we look at it. What is the effect of smoking on cardiometabolic conditions across the different regions in the Republic of South Africa? With this, we can see the higher the prevalence of smoking, the higher the risk of cardiometabolic. Of course, this is not a causality. It's just an association. We find a reasonable level of association between smoking and having this cardiometabolic condition, just because we can leverage on secondary data. This is a follow-up to that particular study. We now look at the median age at the beginning of smoking, when people started smoking. What was the median age of all people that said they are smoking? Again, this was possible because I couldn't have gone to the street of South Africa and be carrying out this type of study and be asking people all those things. But with the availability of secondary data, choosing the right methodology, we were able to get the much needed information and use it to achieve our objectives. So, having said this, the story looks nice, isn't it? But when we are dealing with secondary data, there are obvious challenges and limitations. And we must recognize this and declare them when we are using them. Number one is most secondary data are not collected with research in mind. Therefore, there can be missing indicators. There can be missing characteristics that you would have loved to explore on your own, but they won't be there. So we have to be mindful of this. And of course, it is honorable for any researcher to declare it, that this is a limitation. Declaring a limitation in our study doesn't water down the study, but rather it's just telling the obvious. And of course, as we are mentioning the limitation, you need to quickly say, nonetheless, these are the strengths of my finding. This is why my findings are reliable. Another issue is the data quality and completeness. In most cases, the data are not of high quality, especially for those routine data like all those data that you collect at ports of entry. But surveys are even better. Some of them may lack quality, variability in data quality. Some of them are late. Some of them are not reported. Some of them are not complete. Potential biases. There could be bias because of those missing values. But these days, there are different mechanisms whereby we can actually make up and of course adjust for missing values and estimate them using some statistical procedures. Another issue is privacy and confidentiality of those people that has the data. So you need to follow necessary ethical considerations when you want to use people's data. And of course, there's a need to be able to collect necessary approvals. Another issue is data integration and compatibility. You want to, because the data collected in maybe in Scotland may be different from that in North Ireland. How compatible are the data? How well can we compare them? There can be all those challenges. And again, there can be some codes that be used, such as ICD 1098 codes that have been used. How variability, how has things been streamlined? All these things, they are challenges, and one needs to address them. Another thing is a limited control over data collection. Researchers have no control over how the data were collected. So there can be mismatch between the data and research question. Sometimes you have, however, it depends on those that collected the data. If they've done their job thoroughly, it will be easier, but of course, there are potential challenges. So when we are using secondary data, there are some things we must bear in mind. Number one, what is the source of the data? Where is it coming from? Number two, what is the sample size? Is it big enough? But you can see most of the examples I've given today, they are really big, which is okay. So you don't need to calculate sample size, but you need to declare the power. Is it 90% power? Is it 99%? Because when you have the sample size, you can use it to calculate the power and tell us that this is the power of my sample size. That is the ability of to negate the null hypothesis when indeed it is wrong. What are the data structures? How does the data look like? Which analytical strategies can you use, and so on and so forth? Do you need to weight your data? What is weighting? Okay, in sample surveys, for example, somebody we are doing a sampling and you've interviewed maybe 100 people in Birmingham and 100 people in Coventry. You see that the population of Birmingham is far, far, far above that of Coventry. So when analyzing, we need to adjust for the population of Birmingham so that the influence of the 100 people from Birmingham will be higher than the influence of the 100 people in Coventry when you are analyzing. That is what we call weighting, and it's a proportion of being selected. And of course, do you need to pull the data from the different sources? Another big issue is the hierarchical nature. For example, if you have first selected countries, let me say nations within the UK, and later on you select different areas, maybe Midland, London, Southern England, and so on and so forth. and later you now zero in on the council before you zero in on the postcode. These are called hierarchies. This is data hierarchies, and it is recommended that you recognize that there is hierarchy when there is an hierarchy, and include it in data analysis. Single or repeated measures. Was the data just one-off, or it was longitudinal when you are coming back to collect more and more data? All this has to be, you have to bear this in mind as well. Another issue is the data handling skills. How, do you want to reshape the data? Is it coming in long format or short format? Do you need to collapse? Do you need to recategorize? Do you need to merge? Do you need to index? These are some of the considerations you need to make when you are using secondary data. So what are the best practices in using secondary data? Borrowing from the last slide, the first thing is data management and cleaning. That, in fact, to analyze is not a problem when you are using secondary data. The ability to manage the data, put it in a form that will be very useful for you to achieve your research goal is the ultimate, is the number one, and prominence has to be given to it. Data management and cleaning. The statistical analysis is not usually the problem. Of course, it remains the endpoint, but you cannot do analysis on a faulted data. That is why a lot of efforts need to go to data management, and there is need for expertise in doing that. Another one is ethical consideration. You need to ensure that the data that you are using was originally collected under proper approval. There must be sound ethical consideration. Otherwise, you cannot use it. The blame will be on the owner of the secondary data, the original owner, as well as the person using it. So there's need to check the bookings, what has been said about it, and so on and so forth. And of course, opportunities for data sharing among researchers. One need to consider the need for collaboration and the data sharing when using the secondary data. So it is getting more interesting. Before we go to the final phase, statistics is because everything boils down to analysis at the end of the day. And that's why I put this fable here, that things are not always what we think. There is a need to dig deeper into our data to see what is actually done. For example, when you look at this fable, is a big elephant, isn't it? With different parts, and the six men with challenges with sin, with their sights, were told to say what's the thing they are touching, and of course, everybody would say whatever their hand touches, isn't it? So one touch the wall, it say, oh, this is one touch the side of the elephant, it said this is a wall, and that one touch the ear, it said this is a fan, and so on and so forth. And all of them, because they couldn't see, they began to argue very low for a long time and very loud for that matter. And the truth of the matter is that they are partly in the right, but unfortunately they are all wrong. And that is the power of statistics. Statistics, you do not look at just one side. You need to look at it as a whole. Going to our last webinar, which told us about system. Yeah, statistics is a systematic approach to things, whereby you see things a whole, not just a part. Otherwise, we will get it wrong. So yeah, there's a need for us to employ the right statistics when we are dealing with secondary data. And with that one, I would like to talk about the procedures for analyzing secondary earth data. But before I talk about that, first thing first, let us look at the pre-matter. Before you want to do any study, you don't just do a study because you like to do a study. You need to plan. And the first planning in any research is to have an objective, is to have a goal in mind, a destination. When you are about leaving home, where are you heading to? Are you going to London, or you are going to Birmingham? There may be different routes to get into those destinations. So we need to predetermine, what do I want to? You need to state the main research question and hypothesis, as well as the secondary objectives, and so on and so on, before you can even talk about secondary data. There must be a plan. And that is the first step. And what is the next thing you need to do? you need to design and think about, how do I want to carry out this study? Which study type would be appropriate? How about my sample size and power? Because your objective, which I have shown here, the objective you have determined is the one that will help us, or help you rather, to determine whether you want a quad study or a quad data, or you want cross-sectional, or you want electronic health record. Your objectives will be shaped, or rather, your objectives will shape the type of design that you want and the type of data you want. Although you can still come back and amend the objectives in a way so that the two of them will align. I will talk to that at I will speak about that at my fourth point. So you must include the sample size. How did they determine? That is, people that collected the data. And it is possible that they didn't use a sample size. Maybe it's a general population survey, people that were born, for example, in year 2000. You don't need to calculate any sample size for that, but you need to come and tell us, oh, the sample size is this, then the power will be this. If possible, explain the rationale behind these calculations. The next thing is to identify the data sites that may help you to answer your research questions. You need to do that by identifying them thoroughly. And in that case, what do you need to do? You need to understand the study design and where the data comes from there your data, understand the scope, the context, the purpose, as well as the methodology of the data collection for your using data set, and check for data accessibility. Can you really access it? Would they give me this data? And of course, you need to get familiar with the documentation on the data. For example, you cannot just go analyze the data without looking at the questionnaires, the forms, the pro formas that were used. How about the data dictionaries, user manual that describe the variables coding and the sampling techniques that were used for the data? Because you will need all these ones when you are reporting. You need to get them done. You need to match your available data with that number one thing, your study hypothesis. You need to, there must be a linkage. You must match also with the study design. For example, if you want to study the trend in smoking during pregnancy, what will you need? You definitely need data on smoking among pregnant women. So you must make sure that the data that you are using will be a database of pregnant women, and of course, it must have a question on smoking. And of course, you will now think, because there is a trend. If we are talking about trend, then it should be more than two. So you need at least 3 rounds of cross-sectional data, or at least a longitudinal data that has more than 2 time points. And of course, you now decide on the analysis method. So after that, you have been able to match your research idea with the available data set. Then you need to think about your statistical analysis plan. It's just like an architect that wants to build a house. He needs to sit down and have the picture of what he wants the house to look like in the next 2 years after completion. He needs to have it in mind. The same thing in statistics. You need to sit down and visualize the unseen by stating your statistical methods, which power, which sample size, significance level, assumption. Do you want to transform your data? Are you going to describe the data? Which inferential methods are you going to use? If you have confounders, how are you going to handle it? Are you going to do interim analysis? What about the final analysis? Will you need stratified analysis or sensitivity analysis? And how do you present your results? All these things, you need to document it so that it will be like a Bible in quotes, which you have to follow in the course of the analysis. The next thing will be ethical considerations. I know I've mentioned this slightly under number 3, but you need to think again about the documentation. Check that the original data owners got ethical clearance. Otherwise, it's a no-go area. Make sure that the data was collected with proper informed consent from participants. Obtain necessary approvals to carry out secondary analysis. It is still, because it is wrong for you, if it's even unethical in itself, to go and use somebody's data without the person's approval. So we need to seek approval. And of course, how about data privacy? Ensure that patient data is de-identified or anonymized, especially for data set that involves personal health records. This has to be done. Number 7, you need to prepare your data. Sometimes you need to transform your data. The data, for example, it could have the age could have been how old were you when you did this? Maybe you would not need to categorize it. That is part of data transformation. Sometimes you need to find you may not be able to use data as it is. You need to find the log, and you may even need to collapse and so on and so forth. You need to do variable selection. These are what we do in data preparation. And under the statistical analysis plan, we have spoken about this descriptive statistics and inferential statistics. Think about it. How do you want to do cross tabulation? Do you just want to use charts? What do you want to use? You need to determine it. And of course, you need to do the hypothesis testing and the main analysis, which is inferential. We just want, because in most studies, you don't just want to say this is percentage, but you need to connect statistically. Is this significant at this level? And so on and so forth. Which type of study? Are you using regression? Are you using survivor analysis? Like this chart here across 3 countries, we are looking at timing of first domestic violence after marriage or after living with a partner. We look at it across 3 countries using the power of secondary data for Nigeria, Mozambique, and Kenya. You can see that it is much higher. The risk of experiencing the first domestic violence is higher in Kenya than the 2 other countries, especially after 5 years of marriage. The thing goes up so much in Kenya than in the other countries. You need to adjust bias or confounding in your analysis. There are different methods to engage in doing that. And of course, interpretation, because the number does not make any sense until you've spoken to the data, until you've spoken to the number, you contextualize your findings, you do the comparative, and you speak to it in simple English. You need to interpret it. What does this mean? Make necessary recommendation. And if you need to visualize, use very amazing earth informatics. Use a clear chart that speaks volume. And we all know that one particular image is better than, it could be better. Let me use could be better than 1,000 words. So you need to visualize. And then I think with those 12 steps of mine, I've been able to narrate how we can handle a secondary data. And I'm in the community. If there is anything you would like us to do or to explain or to assist with, we can get my email from the organizers. It will be my pleasure to support us in any way. But peradventure, as we are rounding up, if there's anything that I've not spoken about, which you were expecting, this will be a good time for us as we go to question and answer time to quickly discuss it. I've just opened up this. So please, if there is anything you like us to see that maybe I've missed out that I didn't speak and you would have loved to hear about, please, you can scan this Mentimeter and just state it so that we can quickly talk about it in the next 5 minutes. The code still remains the same. If you've not closed your browser, you can just go back and it will show this one. Thank you. And if you have specific questions, we'll be able to answer that after this. Okay, thank you. I will quickly try to address each of them as they are coming. Yeah, subgroup analysis is very good. For example, let me start by that it is very possible with secondary data analysis. What is a subgroup? You can use any of the characteristics of the individual in your study to divide them. It could be what is your gender at birth, male or female. You can use it to classify people. You can even use their postcode to separate them so that you will know that what is the effect, how does the outcome, what is the outcome like in a particular subgroup population compared to the other. And then, which is very good, we call it stratified analysis. This is a very good way of whenever we do any analysis, it will be good. Even for age, you can show people in higher education or people that are educated up to university, people that went only to college, or people that stopped before college, and so on and so forth, so that you can do some comparison. Please, is there any other one thing you would like us to speak to? Okay. Closely related to that are questions. If there is any question generally, as we try to round up,
Yeah.
please you can
Thank you very much.
unmute and ask us your question.
Yeah, so we've got one question in the chat from Ogechi. And she's asked, do you have to get ethical approval from all the organizations and countries you are collecting and using data from, or are these data openly accessible to everyone?
Thank you so much. Thank you for mentioning that. Now, it depends on the data you are using. Going through my presentation, you see that I've used DHS a lot. DHS is organized by ICF Macro in the United States. Like I said, all you need to do is to apply to that ICF that you want to use their data for this country A, B, C, D for this particular year. And once they give you approval, that is okay. You don't need to go to every country, but it depends on the type of. I've just spoken about the DHS. Some other data may be different, which means that if it is a particular national fertility survey that UK did its own separately, the Spanish did their own separately under different governments, then you need to apply to each of them. But like the mix, that's a multiple indicator survey, for example, housed by UNICEF. All you need to do is to write to UNICEF that I want access to this data, and they will be able to oblige you. Thank you.
Thank you very much for that. Does anyone else have any questions for Dr. Adeniyi?
Oh, okay. Thank you. We have Grant Richard. He said, no specific questions. There has been so much information here. It will be of benefit to viewing the recording and taking it stage by stage. Yes, we totally agree with you, and this will be shared. The presentation and the recording will be shared. Okay, thank you so much. I hand over to Michael. Thank you for coming.
Yes, thank you so much, Dr. Adeniyi, for this session. It was quite informative, and I learned a lot of new things data-wise that you can access just to do research. So also for people working in different local authorities, I guess you can access data from your council's like website and use that. And also, as Dr. Adeniyi has said, you can reach out to him if you have any questions or if you need any support with doing any kind of research or any kind of study, just to to do your work or to again improve health outcomes in your locality. So thank you everyone for coming today. Thank you once again, Dr. Adeniyi, for joining us today, for presenting today. Have a lovely time. Again, we'll share the slides and the recording with you in a couple of days. And yeah, and we'll see you next time. Take care, everyone. Bye bye.